iEcho is hosted by the iEcho Foundation in association with Project Echo from the University of New Mexico. As most of you know, these sessions are held weekly on a Wednesday with various topics being presented. The chat is open for any questions, so if you have any questions, please feel free to post it in the chat. This week we have with us Dr. Modise Mokone from the University of Pretoria, who's going to be presenting a very important topic. He's going to be presenting on Lynch syndrome or non-polyposis hereditary cancers. I think this is quite important. My personal feeling is it's something that's missed a lot in South Africa. We've always postulated that we see a lot of cancer in our young population, especially in the black population. And we've always postulated that they don't get as many polyps and perhaps they follow more of a Lynch pathway. And we know that we have pockets or communities of patients with Lynch syndrome, but I think it's more prevalent in the general population and is often missed. We now pick more of them up due to reflex screening when we find these tumors. But without further ado, I'm going to hand over to Modise, who's going to take us through Lynch syndrome. And again, please post your questions in the chat. We'll try and get to all of the questions at the end. You can share.
Is it fine?
Yeah, you can see. Yeah, that's fine.
Okay. Can I start?
Please go ahead.
Okay. Good evening, ladies and gentlemen. I've been asked to present, as Vikash have mentioned, this important topic, Lynch syndrome, known as hereditary non-polyposis colorectal cancer syndrome. Next slide, please. This medical condition that is not very rare, quite common, but easily missed, as Vikash has mentioned. It's actually an inherited cancer predisposition syndrome of autosomal dominant and due to germline mutation on the DNA mismatch repair genes that makes our people more likely to develop cancers due to this defective repair of the DNA, mismatched DNA. As we mentioned, that is an autosomal dominant manner inheritance. The first degree relatives, mostly parents and siblings and children, have at least 50% chance of having this mutated gene. And this is generally an inherited colorectal cancer, which accounts for almost 3 to 5% of the cases of colorectal cancer. As I mentioned previously, it's one of the 5 DNA mismatch repair genes that are mutated, mainly MSH2, MLH1, and MSH6, PMS2, and EPCAM. These genes that are mutated have actually a variable penetrance. Hence, Lynch syndrome has a variable presentation due to its difference in the affected genes in the individuals. Next. Why do we need to identify patients with Lynch syndrome? It's precisely because patients have at least 25 to 80% lifetime risk of developing colorectal cancer, which is much more common in male and more than women, with a mean age of diagnosis, which is quite young, 44 years in families that meet the Amsterdam criteria that I'll mention about now, 1 and 2. And also to mention that it's not only the colorectal cancer that this syndrome affects such kind of people. It's also what we call extracolonic manifestation. Second most importantly is endometrial cancers and ovarian cancers. It constitutes around 20 to 70% people risk, lifetime risk of developing this kind of tumors. Also, as also mentioned, some of the most important extracolonic manifestation in these patients, it's upper GI, the gastric cancers, duodenal cancers, and upper urinary tract, brain and skin cancer. rarely pancreatic or biliary cancers. Next slide. In fact, it's because of the diversity and very difficult in identifying this kind of patients. In the Amsterdam criteria 1 and 2 have looked at the certain look at high risk patient that needs to be tested for genetic molecular testing. And this has actually improved the diagnosis sensitivity by actually looking at the revised Amsterdam criteria to include not only colorectal cancer patients, but also Lynch, what we call Lynch syndrome associated cancers. So there are criteria that would need to be met to be considered for possible molecular genetic testing. And these are, we need all of the three of the following historically elements should be fulfilled or be present for you to diagnose this patient with Lynch syndrome. As I mentioned, at least 3 or more relatives with colorectal cancer or Lynch syndrome associated cancer, with one of them being the first degree relative of the two. At least 2 or 3 consecutive generations must be involved with having colorectal cancer or Lynch associated cancer. Or at least one of the colorectal cancer must develop before the age of 50. And very of importance that we need to exclude the familial adenomatous polyposis. Next. The revised Bethesda guideline basically looks at criteria that for this patient to be tested for the tumor to be tested for microsatellite instability. You need at least one of the 5 criteria of the following criteria that ought to be met. One of them, colorectal cancer diagnosed before the age of 50. The colorectal cancer diagnosed in a person with 1 or more first-degree relative with Lynch syndrome, which is associated under the age of 50, or colorectal cancer in 2 or more, or a second-degree relative with CRC or Lynch-associated cancer, or somebody who's got synchronous or metachronous lesion, regardless of the age, and the histology of the tumor, especially those who've got microsatellite instability high, in pathology. Those people are supposed to be actually these are the people who would meet what we call revised Bethesda guideline. Next slide. What are the basic hallmark of Lynch syndrome in patients generally? One, it's usually a syndrome that occurs in a younger age. Cancers occur in the younger age, especially the mid-40s. The lesions mostly commonly occur in the proximal to the splenic fracture in 2/3 of the cases. The precursor lesion is usually a small colonic adenoma, unlike in the patient with familial adenomatous polyposis. The tumor tends to grow faster than in patients with a sporadic colorectal cancer because of the dwell time of this patient. Commonly in the sporadic type of colorectal cancer, is usually the dwell time is around 15 years. As for Lynch, it's actually quite fast, around 2 to 3 years. Of importance is that there's a better survival in Lynch syndrome related CRC compared to patients with sporadic colorectal cancer. Next. So as we mentioned initially, what are the genetics in the Lynch syndrome? There are actually 5 most important genes that are involved in the Lynch syndrome. Most importantly, we look at the MSH2, which account for quite the majority of these patients, which are around 60%. MLH1, which account for 30%, with MSH accounting for 7 to 10%, with PMS2 quite a low percentage of patients involvement. The MSH2 and LH1 actually classified as high penetrance and high risk, with more than at least with high risk of 70 to 80% predisposition of patient to develop this kind of colorectal cancers. And the type of cancer in this not only colorectal cancer, but these are patients who are more likely to develop adenoma. And once they develop adenoma, it's mostly in an advanced type of adenoma with high risk dysplasia and mostly they would also have C-cells-rated lesion, and there's high risk of recurrence of or adenoma recurrence in this patient post-polypectomy. Next. The laboratory tests that are important in diagnosing patient with Lynch syndrome, particularly to look at your microsatellite instability. As we mentioned, the tumors have this kind of the microsatellite instability that can be tested by using the polymerase chain reaction. It's very important to identify this kind of pathology in this cancerous patient that you would have picked up either from the tissue or from the surgery. So if you identify microsatellite instability, high microsatellite instability, this is most likely this patient would more likely to be Lynch syndrome. But however, they also need to be confirmed, as I'm going to mention with the genetic studies. So if you do a microsatellite PCR and you find a tumor with high MSI high, the tumor most likely could also be the sporadic type. So you would need to look at, especially if it's MLH1, you do a gene test mutation. If you find BRAF V600, most likely this, if it's positive, it excludes Lynch syndrome. It's most likely your patient would have a sporadic type of colorectal cancer. Another important laboratory test that we do is to assess the MMR protein is staining, to look at the stains of these 5 proteins. If the stain come back negatives, most likely this patient that has got a Lynch syndrome. But if the stains are positive, that it's unlikely that the patient would have most likely would have Lynch syndrome. Next. When to do immunohistochemistry, all patients with colorectal cancer with the age less than 70 years, and all those more than 70 years, if they meet revised Bethesda guidelines or clinical prediction model of more than 2.5%, or anybody with endometrial tumor diagnosed below the age of 50. Next slide. The diagnosis of Lynch syndrome, as I mentioned, actually entails a detailed family history, where particularly the premature colorectal cancer, those who develop colorectal cancer below the age of 50 up to 40, and not only looking at the colorectal cancer, and also what we call Lynch syndrome associated cancers. As I mentioned, your endometrial carcinoma, your ovarian cancers, the upper GIT, especially your gastric and small cell carcinoma. You also need quite a significant, a thorough family history, especially spanning through at least up to 3 generations of all the first, second, and third degree relatives. And all these cancers must be noted as you asked about the history at the time when these relatives developed these cancers. The age is very important at diagnosis. They also you need to look at your Amsterdam 1 and 2 clinical criteria, your revised Bethesda guidelines, and by your tumor analysis, where you look at your microsatellite instability and also your immunohistochemistry. Next slide. So as I mentioned, immunohistochemistry staining of the tumor is quite effective in detecting this mismatch repair mutation gene in around 70 to 87%. That basically known to have actually be associated with microsatellite instability. I know previously there has been debate in terms of who to test to do immunohistochemistry, but we're looking at the costs. But generally, now people are talking of universal testing for all patients who are diagnosed with colorectal cancer to make sure that we do not miss this Lynch syndrome. Okay. The most other important diagnostic criteria that we look at is your histopathology in the Lynch. Commonly, as we mentioned, these tumors are on the right side. And histopathologically, we mentioned that they're actually more mucinous. They're purely differentiated, and they have a signet ring cell lymphocyte infiltration, or a rim of what we call a germinal center producing a lymphoid reaction around the tumor. Next slide. Most importantly, and it's our genetic germline tumor testing. Very important, the indications for this. As we mentioned, the candidates must meet Amsterdam 1 and 2 criteria, must meet revised Bethesda guidelines, as we mentioned previously. The patient, if we've got somebody in the family who's got a known Lynch syndrome, let's say they've got a tumor, colorectal cancer in a premature, that's around less than 50 years, it's an indication to do genetic testing. And anybody who endometrial cancer diagnosed before the age of 50 and personal history of tumor showing evidence of MMR deficiency without evidence of MLH promote hypermethylation. Next slide. How do we go about managing this kind of patients? It's very important that we do especially the colorectal cancer surveillance. It's very important, as this is the most important malignancy identified in patients with Lynch syndrome. When you look at this mutated gene, commonly the MLH1 constitutes 45% causality and MSH2 35, with MSH6 20%, and rarely your PMS2. Basically, the surveillance colonoscopy is very important to be done in important to look at the high definition. You must use the high definition endoscopy and make sure that it's a high quality colonoscopy to prevent the interval cancer. It's very important. The surveillance colonoscopy is main aim is to prevent colorectal cancer and also to detect this colorectal cancer at quite an early stage. The benefit of doing surveillance colonoscopy, it actually decreases your CRC incidence by 50% and associated mortality by 65%. And also, very importantly, it has decreased post-colonoscopy colorectal cancer. Important when to do the surveillance colonoscopy. It's usually recommended that we begin around the age of 20-25, looking at the gene. If the gene comes from the high risk, what we call high prevalence penetrance group, the MLH1 and MSH2, the interval colonoscopy is recommended that it should be done with every 1 to 2 years. And for those who have low penetrance genes mutation, your MSH6 and PMS2, it's recommended that you can start surveilling around the age of 25 to 35 with the interval colonoscopy within 1 to 3 years. Also, you can do surveillance colonoscopy can be done in anybody who's got a family history of Lynch cancer in somebody 5 years younger than that person when he was diagnosed. But also, the surveillance should not be delayed. If somebody presents with symptomatic signs like anemia, rectal bleeding, you can't do that quite immediately. If when during the process of doing the surveillance colonoscopy, you find that the patient was suboptimally prepared, we need to repeat that colonoscopy within 3 years. Next slide. What would be the indications for doing colectomy in this patient group? Anybody who's diagnosed with colon cancer, the colectomy is recommended. Advanced adenoma that cannot be removed by simple endoscopic measures. If a patient cannot follow the surveillance measures that we've mentioned before, it's very important that you look at to do colectomy. The type of colectomy actually been recommended in this kind of patients. It's more like total colectomy with ileoerectal anastomosis. But for people who are much older, you can do segmental colectomy. What would be the risk of patients developing post-colonoscopy colorectal cancer in a Lynch syndrome? It's very important that in Lynch patient that most of the time the type of cancer that the polyp that we see in patients with Lynch syndrome are very cryptic, and it's not a typical polypoid pattern. So it might be very difficult in detecting some of these polypoid lesions. So this is why it's important that the patient must be thoroughly prepared, and you also you must use high definition endoscopy, and also can use endocap to help you to identify this kind of lesion not to be missed, because it's very easy to miss. The other important aspect and reason that why the post-colonoscopy colorectal cancer can develop in patient Lynch, it's more inadequate bowel preparation, or somebody, if you had not completely examined the colon, doing all the retroflections where they are needed. So the likelihood of you missing patient developing post-colonoscopy colorectal cancer is very high. And as we mentioned, depending on the type of the mutation that we have in the Lynch, with the recommended surveillance interval, if patients sometimes they develop fatigue, and then people don't adhere to the adherence, surveillance colonoscopy interval. So this is high risk of patients developing post-colonoscopy colorectal cancer. Just also to mention one important topic that is topical now, the use of aspirin in colorectal cancer. It's actually been found, not only in colorectal cancer, it's actually in Lynch syndrome, that aspirin use, there's been a bit of controversy around how much dose to be used, but the use of aspirin in quite a little bit higher dose has been found to actually reduce quite the absolute risk reduction of cancer by 20% on all cancer, with 34% quite significantly in a patient with the GIT cancers. And as for colorectal cancer, dropped by at least 150, by 50%. As I mentioned, the aspirin dose, some have gone up to 650. And other, but generally the recommended, other literature has mentioned 150, 81 milligram of ecotrin is still fine, but I think it's a bit of a debate. The duration is quite important. If it's been used for at least 2 years, it's got a long-term benefit in this kind of patients. Next slide, please. The extracolonic manifestation of Lynch syndrome, as we mentioned, there are a lot of other factors that contribute, not only that actually accelerate, other than your underlying genetic mutation, your gender, your geographic location, and your ethnicity, and at least your lifestyle and other comorbid diseases also does contribute to extracolonic manifestation, or what we call Lynch syndrome associated colon cancers. Of importance is your endometrial cancers, your ovarian cancer, which we mentioned that it's actually got a lifetime risk of endometrial cancer in patients with Lynch around 20 to 70%, which is associated with MSH2 and MLH1, MSH6, with 10 to 15% with PMS2. And people are saying your surveillance does not necessarily decrease the mortality when you look at this patient. When do you consider doing hysterectomy and bilateral salpingo oophorectomy in anyone who's around 40 years, who has high penetrance mutation like MLH1 and MSH2? Anybody who presents with endometrial cancer, this patient warrants hysterectomy and bilateral salpingo oophorectomy, or anybody who has completed childbearing, who has reached the childbearing stage. Next. What are the red flags in surveillance of endometrial and colorectal cancer that you need to be quite worried. No, endometrial and ovarian cases. Patient who present with abdominal pain, who's got non-menstruate related bleeding or urinary frequency, you need to be quite aggressive in looking at that kind of patient, doing your surveillance protocol and doing your annually your transvaginal ultrasound and your endometrial sampling annually, your annual CA-125 blood test for ovarian cancer. Another important tumor cancer that associated with Lynch syndrome is your gastric cancers. But basically, the ESG does not recommend any routine gastric surveillance in individuals. Safe to mention that they recommend you just test for H. pylori, and if it's positive, you treat. But also looking at the family history. If someone's got a family history of gastric cancer, you need to be much more proactive, especially in the first degree relative. You can do your upper endoscopy every three to 5 years, starting from the age of 30 years. Look at the pre-malignant lesions, especially also going deeper and looking at if there are any duodenal adenomas. Next slide. Small bowel cancers in Lynch syndrome, it's generally small bowel accounts for at least 1 to 2% of all GI malignancies, with a lifetime risk in Lynch syndrome around 1 to 4%, especially your adenocarcinoma. But there are other small cell cancers like carcinoma, stromal tumors. In those 50% of all the small bowel tumors originate in the duodenum, 30% to 33% duodenum, and lastly into the ileum, 75%. And they usually present in a younger age, with a mean age around 20 years. This is quite very young, and they can be very challenging to diagnose because they've got late stage presentation and they carry quite a very poor prognosis. And they're associated mostly with the germline mutation, MLH1, 54%, and MSH2, 37%, and MSH6, 4%. In the same vein, the ESGE does not recommend routine small bowel cancer surveillance in this patient. But if patients got symptoms, can looking at the G-scope, extended duodenoscope, with extended duodenoscope, video capsule endoscopy, and other invasive procedures like double balloon enteroscopy. But this could be mostly in symptomatic patients, basically. Next slide. Pancreaticobiliary cancers, it's a very rare malignancy. It's very difficult to people have looked at more how to do surveillance. Can you subject your patient to MRCP? You know, it's a bit of a controversial here. And endoscopic ultrasound has also been recommended if you have to follow up, especially patients who got a family history of pancreatic cancer. The other important cancer is your upper urinary tract, especially your urethral cancers. They are predisposed to they've got a high 20-fold increase in cancer in patients with Lynch syndrome. Renal, pelvis, urethral, bladder cancer account for 33%, mostly associated with MSH2, which is 73%. The annual urinalysis to detect bladder cancer, usually starting around 30 years. If it's positive, then you would then subject your patient to cystoscopy. Brain cancers, not very common. The lifetime risk is not very common. Usually the mean age is around 64. The common tumor that we see in this patient with Lynch syndrome in the brain is your glioblastoma multiforme and astrocytoma. Just remember also this brain tumor could also be a variant of Lynch syndrome called Target syndrome that it can be associated with adenomatous colonic polyp with your brain tumor that we call Target syndrome. Next. The skin also has been noted that can also be associated with Lynch syndrome. Certain type of cancers, especially your keratoacanthomas, your sebaceous adenomas. can be associated with Lynch syndrome. So, and if there is concomitant visceral malignancy, like in the GIT or urogenital, could still be recognized as part of the Lynch variant called Muto syndrome. The dermatologists have ought to be referred to assess this kind of patients. Next slide. I think on this slide, basically, I think there's a lot of research and in what treatment modalities can be given to a patient with Lynch-associated malignancies. Of importance is the immunotherapy, especially your immune checkpoint inhibitors. The first was to be approved was your pembrolizumab, the PDI inhibitors, which has been found to be quite effective in treating a patient with Lynch-associated cancers, especially with those with a very high microsatellite instability, and even those at the stage where they are unresectable colorectal cancer, metastatic tumors. New on the block now, the people are talking of Lynch syndrome vaccines and the gene therapy. I think next slide. I think from my take-home message from this discussion is that Lynch syndrome is a common hereditary colon cancer syndrome that's not recognized. Actually, I think we miss a lot of patients who have got Lynch syndrome, and because it's as we mentioned, it's an autosomal dominant germline mutation. That means it's 50% of the carriers basically will pass this mutated gene to their children. So it's very important to take thorough family history, as we mentioned, generational history. It's quite important. Quite often, most of the time, young patient comes colorectal cancer, they get biopsies, advanced adenocarcinoma, just sent for surgical treatment, operated. But we forget a very important family, because I think we miss most of the family members. We don't test the gene, we don't request the immunohistochemistry, and I think it's very important to recognize that Lynch syndrome is not colorectal cancer. It's got also increased risk of extracolonic malignancies, your upper GI, your renal, your brain, your skin. So lastly, proper and adequate surveillance of individuals affected and affected family members based on genetic risk profile. It's very important. Thank you.
Thanks, Modise. Let's just go to the chat. If anyone has any questions, please send through your questions or unmute and ask. Feel free to unmute. Just one question in the chat. When do we do immunohistochemistry in Lynch syndrome? I suspect the question may have been, when do we do it in all patients, or when do we suspect Lynch syndrome rather in Lynch syndrome? But I think you have covered that in your talk. So you showed us the Bethesda guidelines, the Amsterdam guidelines, and those are the patients that we really should suspect it in. And what you really need to do is ask your pathologist to specifically do the mutations. There are some labs, at least in South Africa, and some centers that are doing reflex testing on colorectal tumors, especially in younger patients. So if you send through a sample and the patient is less than the age of 50, they get reflex mismatch repair testing done. And that's probably a good strategy to pick up patients or communities who might be, benefit from targeted screening rather than population-based screening. But it's essentially those criteria. I also usually send it off or ask for it if I suspect it in patients. For example, in the last 2 months, I had two patients who both had very small polyps, about a centimeter and a half, but with demarcated areas which were malignant. The one was endoscopically resectable and the other wasn't. I sent the patient for a right hemi. But you find these small polyps, and we tend to overlook these polyps because we're looking for the big cancer. But in these patients, you see these small polyps because their dwell time is much shorter to cancer. So you see these small little polyps, 1.5 centimeters, and they already have cancerous or malignant changes in them. So I think using Amsterdam criterias, Bethesda's criterias, family histories, synchronous, metachronous lesions, patients who have tumors with or malignant polyps which are small. I think those patients should be tested, and you need to again ask your pathologist specifically to do the mismatch repair genes. Do you want to add anything to that, Modise?
Look, I agree with you. I mean, it should be automatic in patient to send for immunohistochemistry, especially patients. I mean, the family history is quite important in this setting. Uh, I mean, if somebody's got quite significant first degree relative who's had colon cancer, maybe one or two, I wouldn't hesitate. Even it doesn't have to be less than 50. I mean, 60, 65-year-old, you'd still want to send, because I think most of our time, a lot of patients get missed. We see them when they pass the age of 50, then we say, the literature says 50, why can't you not test for them?
Yeah, so I actually had a discussion with Professor Hale recently, and he also told me that he's picked up quite a few of them, older patients with colorectal cancer with no given family history, and he's picked up a few of them. So your point is well taken that it's not only patients that are less than 50 that get Lynch-associated cancers, especially if you're carrying the lower risk genes like the PMS2s. They can present later. So if you suspect them endoscopically as well, I think we should be looking for them because it has massive implications on patients' families. Prof, do you have anything to add?
Yeah, I think it's quite interesting. Can you tell me how many patients you've seen and what are you doing about documenting them? Because obviously in the Western Cape, there's a large number of publications regarding a cohort that were discovered here over about 35 years ago that Professor Goldberg has been following up for years. And there's an annual screening program for those affected. But what's your protocol in your unit when you identify one of these individuals? Because I think myself and Dr. Kutsia, a surgeon who was in the colorectal unit, we wrote an editorial in the SAJS about a plea for a national registry.
I saw that you wrote that about 2 or 3 months ago.
No,
Yeah.
it's quite a few years ago now, and it was prompted by some research that was done on immunohistochemistry staining, because MSI staining is also quite expensive to do on everyone. Again, obviously, if you go to Europe and America, MSI staining is done on all these cancers. Again, it's obviously not specific for the syndrome, but it gives you an idea as to who you can take further. So immunohistochemistry was promoted as a cheaper way forward for trying to identify these patients in hindsight by looking at their cancers and then going backwards and identifying their um, family history. And do you send your patients to do you have a system that they go to a genetic counselor, or how exactly do you handle? Because that's one of the benefits that happen from this is that they set up a whole support network that includes the genetics and includes
Yeah.
the the counseling of the patients as you go forward and their families.
Yeah, so there was a paper, I think also Pam Goling's group that published also a few months ago, I think also in SAJS, and it was talking about colorectal screening, and they were advocating to do targeted screening. And one of the ways to do targeted screening is to do reflex testing to identify these pockets of patients. In my own practice, I've seen two of them this year, basically. I do, of course, have a massive referral bias because I do get all of the patients with the polyps. So what I have done for them is definitely genetic testing, and I have counseled families to go for genetic testing as well. So the one patient was quite interesting that I saw. She was a 85-year-old female, very lots of comorbidities. Parkinson's, quite frail. Interesting that she has a history for about 30 years, 40 years. So she had a right hemicolectomy for a malignancy. She then had some sort of surgery done on a transverse for, I'm not sure if it was benign polyps or malignancy. She had some sort of surgery done in the sigmoid. And when you probe her, she had something done in the uterus as well. And she managed to make it to age 85. Well, now she had another malignant polyp in the rectum, which unfortunately we could remove endoscopically with the EED. But she made it to 85 with 3 surgeries on the colon plus something in the uterus, and yet wasn't diagnosed, was undiagnosed till now. And it might not have much bearing for her being very comorbid at age 85 and not a surgical candidate, but for her family, it's got massive, massive implications. So I sent her family, basically, all of her kids for genetic testing. And yeah, I advised them on colonoscopies as well. So that's what we usually, or that's what I do at in our center and at Donald Gordon. But yeah, I think the point of that case is really that they go missed. This was a lady with multiple surgeries. The index, or we should have suspected it at the first metachronous lesion.
Yes. Well, and my other question to Dr. Modise is, now screening guidelines are being shifted downwards in most European and North American countries. Now the screening age is being recommended to be at 40. Again, that sort of starts to come into the categories that you're seeing here for this form of hereditary cancer. So again, obviously, awareness is something that's going to detect more cancers, and obviously the ability to test them appropriately. So how do you factor in the new screening guidelines, given that there's no screening program in South Africa? And again, there's no real capacity to be able to do it on a national basis. So how do you think the idea that we put forward of using these groups as a starter for 10 for screening, do you think that's a good idea?
Look, I'm just looking at the sporadic colorectal cancers that we're not doing much in terms of even in terms of just screening people just for non-inheritary cancers. What about somebody with hereditary colorectal cancer like Lynch syndrome?
Yes. Again, so it's a good place to start, isn't it?
Yes.
I think it's a very good place to start.
We're going to hit a wall, you know. We can't manage the current crop of patients that we have. Now, to get a sonar to do pelvic transvaginal sonar, it's a mission. I'm not saying it's a mission. No.
Yes,
you get histology 2 months quite late. So even your surveillance interval, it's going to be a problem. Especially in the public sector, it's quite full. Hey, it's going to be a problem, I must say.
Yeah. I think what Prof is also maybe alluding to is that we don't have capacity to do population-based screening, but what we should be looking for is targeted screening, and these are the perfect, or these are the patients we should identify and focus our targeted screening on.
So again, my question comes back to you. I don't know if there's some other questions, but my question comes back to you. But how many families have you identified in Pretoria that you know of that are around? I'm asking.
Look, I had one patient. He's around, I think it was around 40 that I saw, a male guy. He had a transverse tumor, and he had also the sister had a hysterectomy, but it looks like it was cancer. We're not sure whether it was endometrial, because quite often you don't know what was the indication for surgery. And he also had another. He had also a brother who had colon cancer. We requested this the genetics, the studies, your immunochemistry. They usually done in private because the family could afford. They all came back negative. Your MLH1 all negative. So we thought this most likely represented a Lynch syndrome. Only to find.
So currently you haven't identified any.
Not so far. I guess we're missing a lot in hospital because we don't commonly request, even when you request immunohistochemistry, it takes eternity.
Yes. I think
Sometimes it's not done.
there is a group that Professor Goldberg has been involved with, again, in relationship to hereditary cancers as a starting point, not just for colorectal cancer, but for cancers including breast and other areas. It's called the South African National Cancer Preventive Services. They're looking for people to join them, but they're trying to actually standardize what the NHLI will do for assessing colon tumors so that it can be standardized and the report can be standardized. So there's a lot of basic standardization that needs to be done so you can start to find out. Because currently, apart from the big group that's been followed up for about 30, 40 years in Cape Town, everybody else's experience is one or two or three or four. And again, obviously, the senior people might have seen 5 or 6. But if you get them all together, they are self-proliferating. And even more valuable is FAP, because obviously they have 100% risk of developing the cancer. And again, if you develop one or two of these families, you start to make inroads into actually making a difference for the individuals with those hereditary cancers in reducing mortality and providing them with surgical solutions that might be curative. So I think it's a very good way to go. But yeah, you've outlined all the ins and outs of the whole process, but we need to go back to square one to make a start, I think.
So, Prof, maybe I can ask you a question from a surgery point of view with regards to extended surgery for all of these patients, or standard surgery, or total colectomies for these patients, because all of our guidelines and everything's based on international data. But even if you look at the international data, surveying these patients with Lynch syndrome, about 50 to 60% of patients with MSH2 are going to get a metachronous cancer in about 15 years. So almost half of them are going to get a second cancer at about 15 years. And if you look at surveillance protocols, they all say, they say ESG at least says survey the patients every 2 years. But if you look at the data for the patients that get a metachronous cancer, about 50% of them get it within 2 years. So the argument is, should we shorten surveillance periods? Are we not doing adequate colonoscopies, or is it due to non-polypoid growth? The non-polypoid growth is a little bit controversial. My personal feeling is that there are small polyps that we're missing, but there's a bit of controversy there. And they looked at studies where they did different surveillance periods. There was a study between Finland, Germany, and I think the Netherlands. And the one does 1 year, the one does 2 to 3 years, and the other one does 2 years. And their outcomes are the same. So they were saying shortening the interval is probably not the answer. They also looked at studies where they did colonic chromo endoscopy to see if they've picked up more adenoma specifically in Lynch patients, and they didn't. But the crux of those studies these were studies done in expert centers, which have endoscopists with already very high ADR rates, endoscopists who are used to dealing with polyps and colon cancer and are very adept at that. So the message from there is that these patients, when you identify them, to me, should not or should be followed up in centers that are used to doing polypectomies. They're used to surveying high-risk patients. They're used to surveying IBD patients, for example, and also have tools to deal with what they're going to find in terms of resections. But Prof, do you think every patient should have an extended resection? Should every patient in South Africa, given that we don't have good quality surveillance, should every patient have more extensive surgery?
So Stupart, I think Doug Stupart, who worked with and did his PhD on the data, they published on segmental and total collector. And again, they had several recurrent cancers in the segmental colon. So again, I would think if you've got the 80-year-old or the 75-year-old who the syndrome hasn't been discovered and they present with a limited cancer, then it may be worth doing a segment, as the functional result might be better. But I think if you're looking for a cancer operation in a young patient, then I think most people would opt for that. Again, you have to counsel the patient because that's quite a morbid operation with an increased stool frequency, but they had no recurrent cancers in what little bit was left of the colon when they did a total colectomy or near total colectomy. And the other group that's a really interesting group, because they also have an accelerated pathway, is the PSC group, again with inflammatory bowel disease. And they're again the surveillance intervals. And I don't know enough about all the genetic testing, but I think very much some of these the exact defect is predictive of what cancers they might get. I think that's becoming clearer. For instance, they screened for urothelial cancers in one of the projects in Cape Town and found absolutely none, primarily because they weren't, the mutation here doesn't really have the risk of urothelial cancer. So I think it's important to know exactly the genetic profile of these. And I think that testing is becoming cheaper. And I was involved in a costing study in relationship to finding out the best way to treat suspected individuals with the syndrome. And again, that involved immunohistochemistry testing. It's actually unbelievably effective in identifying them with a very high yield in patients who actually have the syndrome. So, yeah, and again, I think one patient that I saw was scoped by a colorectal surgeon from Edinburgh. And then he was scoped by Professor Goldberg, and he actually came back a year early. And when I saw him, he had a polyp of about 3 centimeters, right, in the right side of the colon. So I think because of this variable penetrance and the natural history is not so predictable as it is with FAP, then it means the interval is just not known, and you will still miss cancers. But I think if you get them on the end of a colonoscope, and again, that's the other thing, is that if this is lifelong surveillance and you're surveilling relatives, you really do want to know who's got the gene, and that will reduce your volume of colonoscopy quite considerably once you do genetic testing. So genetic testing is definitely what you want to do once you've to establish that for the relatives that you're going to follow up. Otherwise, you're going to be colonoscoping a lot more patients than you need to.
Yeah, I think your 2 points tie in very well, and perhaps also genetic studying or genetic testing should determine who gets a extended resection as well. Because we, like you said, we do know MLH1, MSH2 are much higher risk than PMS2, for example. So that definitely should play a role in who or what therapy we offer to which patients. The upper GI cancer issue is quite contentious as well, and some guidelines say screen and some say don't screen them. Modise showed the Europeans say don't, but the Americans say do. They say gastroscopy every 1 to 3 years. They all say look for HP and eradicate that, but it becomes quite difficult and quite contentious about who we should be doing uppers for as well. It's
Perhaps
not
I see Chris is anxiously looking there. We haven't gone over time, have we, Chris?
No, I just wanted to make a point that, there are form thrust versions of the syndrome. So the thing is not to tear your hair out trying to fulfill the criteria. If you've got a couple of alarm symptoms, young age, maybe one family, first degree relative with colon cancer in the index patient, now that we've got good genetic backup and geneticists that really look at our patients closely and it's easily accessible, I really have a low threshold now for getting genetic backup on these patients or genetic advice on these patients.
Yeah.
I mean, the thing is to have a high index of suspicion, and rather than not send because you don't think they fulfill exactly the criteria, just send, even if you suspect there might be, a genetic basis to this polyp or cancer.
Yes.
Thank you.
If there's anyone in the audience with experience or treating a family with it, please do comment. We're very interested to hear experience outside of South Africa as well. So if there is anyone, please do comment and share your experience with us as well. But I completely agree with Prof. Cassanides as well. If you are concerned, if you're suspecting it, ask your pathologist to look for the mismatched repair genes.
Well, I think we've probably exhausted Lynch syndrome. Maybe next time the next hereditary syndrome will be FAP, which is another very good topic to cover. Anyway, it remains for me to thank my co-chair, to thank GASA and the Gastro Foundation for putting this together with iEcho, with Mexico Echo, and through iEcho. And just remember that these are recorded and you can access them on the Gastro Foundation website. And I believe next week is IBD, and that might even be the last one of the year. And
second last.
Oh, sorry, forgive me, second last.
Pathology will be this is the last lower.
Yes, and the last endoscopy session for this year. So we look forward to seeing you next year in terms of endoscopy, but please tune in for the next couple of weeks for the other topics that are being covered. And once again, thanks to everyone. Goodbye.
Thank you, bro. Thanks.
Excellent. Thank you very much. Thank you.